conducting a session on AF, particularly focusing on stroke prevention and managing cardiovascular risk in people with AF. My name is Helen Williams. I am a consultant pharmacist for CVD and working with UCL partners on the development of our proactive care frameworks. And this is part of a series where we've been looking at how do we deliver some of the national targets and indicators that we've got, in particular around AF. We're thinking obviously of QOF. So just first of all, a reminder of what we're aiming to do in AF. So we're trying to move from 79% detected prevalence up to 85%, and from 84% of patients being anticoagulated with AF to 90%. And these were 10-year ambitions for the NHS as part of the long-term plan, which is aiming to prevent 150,000 heart attacks, strokes, and cases of dementia. So AF is contributing to that. As we improve our management, our detection and management AF, we're protecting people, particularly from stroke, but from other cardiovascular events as well. And that helps to deliver our long-term plan. So AF is a bit of a success story in some ways, in that we've achieved our 2029 ambitions. At the moment, we're at about 88% prevalence if you look at the data from QOF and also from OHID, so the Office for Health Inequalities and Disparities. Every now and again, we'll model the number of patients we expect to have AF across the population in England. And the last time they did this, it was around 1.5 million people. We've now got 1.3 million people on, or more than that, on GP registers. So an 88% rate of detected prevalence, which is great. We were aiming for 85% as our ambition. It still means we've got around 167,000 people with AF that's currently undetected. And as long as AF is undetected, if they've got risk factors, they will be at risk of stroke. So ideally, we would identify these patients so that they could be treated. If we look at anticoagulation, again, another part of the success story, our original aim was to get to 90% rate of anticoagulation. And we're currently at 90.43% of people on the AF register with a CHADS-VAS score of 2 or more prescribed anticoagulant therapy, and that data comes from CVD Prevent. This shows all the ICBs in England. You can drill down on CVD Prevent to look at every PCN in England and every practice in England. Usually as we get to ICB level of data, the variation is smoothed out, but there's still significant variation across these ICBs, with the highest performers, not far off 95% anticoag rates, and the lowest performer, a real outlier, that low performer, at just over 80% rate of anticoagulation. And clearly, the further right an ICB is on the chart, the more opportunity there is to review what they're doing and identify patients who should be anticoagulated but currently aren't. So as I said, we're aiming for 90%. We're just over 90% now, but it still means 100,000 people with a CHADS-VAS score of two or more, who are not currently receiving anticoagulation. And I'm sure you're aware that there have been some changes in the QOF, and the maximum threshold for anticoagulation on QOF now is 95%, which you could say is a new ambition. We can drill the data down to practice level as well, as I said. So there is a very, very thin line for every GP practice in the country. There's 66,700 or so GP practices in the country. So on this graph shows all 6,700 practices and how they're performing in terms of anticoagulation. And you can see there's more variation than we saw with the ICBs. Some practices at 100% rate of anticoagulation, and some as low down as 38.5%. So opportunities, again, on the right hand side of this chart for practices to review what they're doing and look at where the more patients that should be anticoagulated than are currently anticoagulated in their locality. So CVD Prevent gives you all this data. As I say, it's freely accessible. If you Google CVD Prevent, you can start looking at, well, how is my practice and my PCN and my ICB performing? As I said, we have some slightly adjusted QOF indicators now for AF this year, derived really from the old IAF indicators. So obviously there's no finance attached to keeping a record or a register, but important that you have an AF register, and that patients on the AF register have a CHADS-VAS score calculated, and if the CHADS-VAS score is 2 or more, that they should be offered initially a DOAC. So DOAC's a first line now for anticoagulation in AF, or if they can't take a DOAC because it was declined or it's not suitable clinically, they should be offered a vitamin K antagonist. So moving towards more DOAC use and less warfarin use. But you can see on the right hand side on this chart what the threshold is now. So you don't get paid if you have a lower rate of anticoag than 70%, and your maximum payment kicks in at the higher threshold of 95%. And that aligns, as I say, with the IAF. So if you're thinking about your AF population, important to think about, well, who should we prioritise for review? And the UCL Partners Proactive Care Frameworks help you cohort your patients, stratify them, and identify patients who should be or could be the highest priority. So rather than just working through them systematically by name, alphabetical name, or by birth date, you can proactively call in those that might have the greatest need and the greatest early benefit from intervention. So you can see the stratification we have for AF down the middle of this slide. So priority 1 are your AF patients not on anticoagulation. They should be having a CHADS-VAS score every year. If the CHADS-VAS is 2 or more, there should be a consideration of whether anticoagulation is indicated. Priority 2, we have patients who are with AF but on anticoagulation and antiplatelet therapies. This is because these patients have a high risk of bleeding. There's an opportunity in most cases to deprescribe the antiplatelet and just leave them on anticoagulant monotherapy. They do need to stay on both, then there's the option of adding a PPI. Priority 3, those patients who are on warfarin or an alternative vitamin K antagonist. NICE now says that patients on warfarin should be considered for a switch to DOAC. It's not a mandated you must switch, but we know that DOACs are at least as effective as warfarin, and they are safer because they're associated with a very significant reduction in the risk of intracranial hemorrhage, between 50 and 75%. So we really should be looking at these patients to say, do they have to have warfarin? Could we move them to DOAC to minimise the risk of a catastrophic intracranial hemorrhage? Priority 4, patients on DOACs whose renal function hasn't been done for 12 months or more because they've clearly fallen out of the appropriate DOAC monitoring schedule. They should be pulled in with a view to checking their creatinine clearance and checking the DOAC dose is correct. And then finally, everyone else will fit into priority 5. They've had renal function checked reasonably recently. They should be scheduled for their routine annual review. Opportunities for the wider workforce to support patients with AF with gathering information, self-management and education and behaviour change, while our prescribing clinicians can really focus on those that need more medical interventions, whether that's for the AF itself or to reduce their global cardiovascular risk, so addressing other risk factors. So within the proactive care framework, we've got quite a lot of resources to support practitioners. So guidance on how to start a DOAC, how to assess stroke and bleeding risk with CHADS-VAS, HAS-BLED and ORBIT, how to accurately calculate creatinine clearance. There are errors in the GPIT systems, particularly system 1, in terms of calculating creatinine clearance. It's important that you can address that. Guidance on dosing in non-valvular AF. So how do I decide what dose of DOAC to give, how to review patients on DOACs, how to make the right choice of formulation, and then guidance on those patients who are on anticoagulation and antiplatelets, What do I do about that? Information on warfarin monitoring, warfarin to DOAC switching, and also information on DOAC to DOAC switching. So those are the resources we have. And what I thought we'd do is just use a case study to work out how we might utilise this package. So our case study is 71-year-old retired teacher Sally. She has long-standing AF, hypertension, and has had a prior myocardial infarction. Her blood pressure was well controlled at her last visit, but it was over 18 months ago because it was the interruption due to COVID-19. She is currently treated with aspirin, 75 milligram daily, presumably linked to her myocardial infarction in the past, amlodipine, ramipril 5, and atorvastatin 20. When you run the AF searches, she would come up as a priority 1 patient because she's not currently on anticoagulation to prevent stroke. And NICE is very clear that we shouldn't use aspirin monotherapy as a stroke prevention strategy anymore in AF. Patients must be considered for anticoagulation. So we might think, well, what can we manage and monitor remotely for Sally? Does she need lifestyle advice? Does she need any amendments to her drug therapy for her AF, for her blood pressure, for lipid management, and are there any other concerns? So the first step might be a phone call from one of the wider workforce and ours role, perhaps, or a healthcare assistant. It could be a phone, it could be a video consultation, opportunities to text. We've got lots of resources in our pack that are simple to share by email or by text to patients. So that first conversation might be a bit about education, self-management and behaviour change. Does she understand what AF is, what blood pressure is and what cholesterol? And our supporting documentation for these proactive care consultations helps these staff members deal with all 3 of these at once. It isn't like a script for AF, a script for blood pressure, a script for cholesterol. It's a consultation guide that takes into account all of these possible scenarios. So the patient might be provided with information and signposted to the British Heart Foundation website because there's lots of support there around education and self-management. Ideally, we want a blood pressure off Sally. She may have a blood pressure machine at home. She has got AF, so we'll need to take repeated blood pressure measurements to get an accurate blood pressure from her home readings. You need around 16 readings average to get an accurate BP in people with AF when you're using these automated machines. The other option, of course, is she comes to the practice for a manual blood pressure. And you might activate something like the AccuRx Florey so that she gets reminders to do her blood pressure monitoring morning and evening for 4 days. So ideally 2 readings, morning and evening for 4 days, all averaged. We've got lots of signposting links to videos on how to monitor heart rate and heart rhythm for patients. You might want to know what her pulse rate is, for example. We know she's in AF, so rhythm is less important for her as an individual. Support for mental well-being is built into all of our packages. And the HCA might start to collate some of the information that would be needed for a consultation around prescribing for a prescribing clinician. So home blood pressure monitoring can be performed in patients with AF. You can see on the left-hand side there that we recommend an average of multiple blood pressure readings, so around 16 readings taken over 4 days, average them and see what the result looks like. The other option, of course, is a manual face-to-face blood pressure. So in terms of the information that might need to be collated before a clinical consultation, you'd want her average BP readings, an indication of her heart rate. We know it's going to be irregular, but because she's in AF, but her heart rate's 94 beats per minute, so not past AF. We'd need a CHA2DS2-VASc score and a HAS-BLED or ORBIT score. Her CHA2DS2-VASc is 4 and her HAS-BLED score is 2, but that would reduce to 1 if we stop the aspirin. Her body weight is 76 kilos. She has a BMI of 27, so some option for a bit of weight loss potentially. Serum creatinine is 132. Her total cholesterol is a total cholesterol of 4.6 and non-HDL cholesterol of 3.7. She has an established diagnosis of cardiovascular disease because she's had a heart attack. So for QOF purposes, we should be aiming to get her non-HDL below 2.5. So she's quite significantly away from that. She does pick up her medicines regularly, reasonably regularly over the last 9 months. So that's encouraging. So hopefully you're all aware of the CHA2DS2-VASc score. We have the scores in the pack. The risk factors that are included in CHA2DS2-VASc are the presence of congestive heart failure, hypertension, being over 75, diabetes, prior stroke and TIA, the presence of vascular disease, aged between 65 and 74 years, or female. So she has hypertension, which gives her 1 point. Vascular disease, she's had a prior MI. She's aged between 65 and 74, and she's female, so she has a score of 4. And if we treated every patient with a CHA2DS2-VASc score of 4, if we treat 1,000 patients with anticoag, we'd prevent 38 events in that cohort of people. So quite a significant impact from anticoagulation, helping you to quantify the benefits to her as an individual. NICE says we should either use HAS-BLED or ORBIT to assess bleeding risk when we're considering anticoagulation, although the decision to anticoagulate should be based on the CHA2DS2-VASc score. The bleeding risk assessment is to help us quantify the bleeding risk and think about whether we need to identify and address modifiable risk factors. So NICE have recommended ORBIT, but ORBIT hasn't been necessarily embedded in all the IT systems yet. And NICE says we can use alternatives until that happens. So if you haven't got ORBIT embedded, you can use HAS-BLED as an alternative. I actually quite like HAS-BLED because it points you to some of the modifiable risk factors, which ORBIT doesn't. So a slightly restricted list of risk factors included in ORBIT. So for this individual, her HAS-BLED score is 2. Which means for every 1,000 patients with AF that we anticoagulate per year, we would expect an additional 12 major bleeds as a result. So 38 strokes avoided at the cost of 12 additional major bleeds. So definitely in favour of anticoagulation. So we've got this information now. We know her CHA2DS2-VASc and her HAS-BLED. It might be time for the prescribing clinician to come along and think about, well, how well controlled is her blood pressure? It was above for the 140/90 target, so we may need to do something there. What do her blood results look like? And obviously the risk, stroke and bleeding risk scores. Really important, I think, that prescribers revisit lifestyle issues just as a reminder, and making sure that they're linked into the system for follow-up by a social prescriber or a health and well-being coach if that's appropriate. So for her it might be weight loss, diet and exercise. We need to explore if Sally has any concerns about or side effects with her current medicines, and just explore if there is any sign of non-adherence. Patients can be picking up their medicines regularly. That doesn't necessarily mean they're actually taking their medicines regularly. So really important that we have that conversation and identify any concerns. And then finally, we've identified that her CHA2DS2-VASc is 4 and her HAS-BLED is 2. We should be offering anticoagulation in line with NICE guidance. So having that conversation, offering a DOAC, discussing the benefits and risks to her, taking into account those stroke and bleeding risk scores, and helping her or making with her a shared decision. Then going on to ensure appropriate dosing and monitoring is in place. And you might refer to community pharmacy for the new medicine service, so she gets support around her the first 4 to 6 weeks of starting the anticoagulant around adherence. And also, we should be considering stopping the aspirin to reduce her bleeding risk. Patients with stable coronary disease do not need aspirin alongside anticoagulation in AF. The antiplatelet therapy should be stopped. We'll look at that in more detail because we've got resources to support all of this decision making. So the first thing we have is a step-by-step approach to initiating a DOAC. First of all, checking the indication and making sure there are no other contraindications. So non-valvular AF means essentially excluding patients who have prosthetic mechanical valves, or known moderate to severe mitral stenosis, we would routinely use warfarin in those patients. DOAC is often considered contraindicated if there are clotting disorders, such as antiphospholipid syndrome. Some haematologists will treat some patients with antiphospholipid syndrome with DOACs, but that's a specialist decision. So essentially to you, if they're on warfarin for antiphospholipid syndrome, we wouldn't be messing with that. But also thinking about pregnancy, breastfeeding, or planning a pregnancy where we wouldn't be using DOACs. We might need to seek specialist advice. We've obviously checked the CHA2DS2-VASc, and we should be offering anticoag because the CHA2DS2-VASc is more than 2. Next, we need bloods, so renal function, LFTs, clotting, and FBC. So the first most important thing is here that we can calculate creatinine clearance. So we also need an up-to-date body weight, and there's a link to the creatinine clearance calculator, so we make sure we do it accurately. Creatinine clearance is important because dabigatran is contraindicated if creatinine clearance is less than 30. And apixaban, edoxaban, and rivaroxaban are not recommended when creatinine clearance falls below 15 mils per minute. But it's also important because it impacts on dosing. So people with lower creatinine clearance will be offered lower doses of the DOACs to minimise bleeding risk. We've talked about HAS-BLED and ORBIT and the importance of that, but the next step would be identifying modifiable bleeding risk factors. And we've got a link to those. The shared decision-making discussion, which we've already highlighted, and making sure we're choosing the right DOAC at the right dose. And then finally, supporting the patient with appropriate patient counselling and making sure the correct long-term monitoring and follow-up is in place. So all of these things that are linked in blue, if you click on them, takes you to the relevant part of the proactive care framework. So we talked about the importance of creatinine clearance calculations. Patients at extremes of body weight, less than 50 kilos, it's really important we use actual body weight. So we're not overdosing the patient. And there's a question mark about people who are of extremes of body weight. We used to say 120 kilos. We're kind of moving more now towards 150 kilos. With DOACs being fine in that range. But if the patient weighs more than 150 kilos, you might want to seek specialist advice. Using recent renal function is important. So ideally check within the last 3 months using a recent body weight. So at least within the last year, more recently if they've had significant health issues, maybe lost weight or gained weight. Being very cautious with the GP IT systems around calculating creatinine clearance, because sometimes they make assumptions that we wouldn't do and default to ideal body weight. We should be using actual body weight. And there's a link to a standalone calculator so you know exactly what's going on. And then depending on the creatinine clearance result, you can either initiate or adjust the dose of the DOAC. So our default position should be with DOACs, the standard dose. So for apixaban, 5 milligram twice a day, dabigatran 150 milligram twice a day, edoxaban 60 milligram once a day, and rivaroxaban 20 milligram once a day. We should only use the reduced dose if the patients meet the criteria for the reduced dose. And yet we often see people, particularly with apixaban on low dose, when they don't meet the criteria for it. So we're not giving them adequate stroke prevention, but we're exposing them to all the risks of bleeding. So we must give people the dose that's correct. And the things that affect the dose in general is the creatinine clearance. As you can see in all of these, the creatinine clearance has an impact. And then for some of them, age, body weight, or interacting medicines. So just really important that I always think for dosing with DOACs, A, B, C, D, age, body weight, creatinine clearance, drug interactions. If you've taken all those into account, you will get the dose correct. One of the other areas to consider is the issue of antiplatelet therapies. This used to be in the IIF last year. It isn't in the IIF anymore. But really important that we are identifying patients who can stop antiplatelet therapy if they're on anticoagulant therapy to minimise the bleeding risk. So This table just helps you go through the process. For patients prescribed aspirin, for example, for prime prevention of CVD, well, that's easy. We don't use aspirin for prime prevention of CVD anymore. We don't use antiplatelet therapy for prime prevention cardiovascular disease. So if you're needing to initiate an anticoagulant, or if they're already on an anticoagulant and an antiplatelet, if it's for prime prevention, you can just stop the antiplatelet. Worth also double checking people aren't doing something funny like buying aspirin over the counter because they heard it's good for your heart. You know, we don't routinely recommend it anymore, but historically patients did used to go and buy low dose aspirin over the counter because it meant they didn't have to pay a prescription charge. It's about 75 pence for the aspirin, as opposed to, I don't even know where we are with prescription charges, 10, 11 pound or more. So just to be a bit wary of over the counter aspirin as well. In patients who have pre-existing cardiovascular disease, so we're talking about secondary prevention now. So if they have a stroke or a TIA, often they'll be on clopidogrel monotherapy. Similarly with peripheral arterial disease, now we tend to use clopidogrel. For stable coronary heart disease, we often use aspirin monotherapy. So if they're on antiplatelet monotherapy, it could be aspirin or clopidogrel for these patients. There's also a very, very small cohort of patients with stable coronary disease or peripheral arterial disease who could be on low-dose rivaroxaban, 2.5 milligram twice daily with aspirin. That's recommended now as an option by NICE. Not many people are using it. The vascular people like it probably more than the cardiologists. So you may see more people with peripheral arterial disease on low-dose rivaroxaban, 2.5 milligram twice a day with aspirin. So if we want to start an anticoagulant, if they're just on antiplatelet monotherapy for stable disease, CVD, we should stop the antiplatelet, start the anticoagulant. If they're on low dose river with aspirin, obviously we can stop the aspirin, but we need to increase the DOAC dose to a full AF stroke prevention dose. So for rivaroxaban, that will be 20 milligram for most patients. Some patients might need a dose reduction to 15 milligrams. So primary and secondary prevention of CVD, we should be looking to stop antiplatelets. The only time it gets a little bit more complicated are patients who've had recent acute coronary syndromes or stents put in. So if they've had a cardiac or vascular stent or an ACS within the last 12 months, they could be on aspirin with clopidogrel, aspirin with ticagrelor, or aspirin with prasugrel. These are complex patients. They've had a recent coronary event or an intervention, and really you should seek specialist advice. Most cardiologists and vascular surgeons won't want people on triple therapy. They occasionally use it for a month post-procedure in people that need anticoagulation, so aspirin plus clopidogrel plus an anticoagulant. They'll want to minimise the duration. They might want to move from ticagrelor or prasugrel to clopidogrel as a preferred agent because it's less potent in terms of bleeding risk, and they might want to say put the patient on clopidogrel with the anticoagulant for 12 months and then stop the clopidogrel so they go on to anticoagulant alone. So that's a complex decision, and really you should be speaking to the specialist. If it's more than 12 months after the ACS or stent placement, they should have gone down to antiplatelet monotherapy. They may have been left on dual antiplatelet therapy inappropriately. Have a look at the discharge summary. Again, in those patients, we should usually be able to just go to DOAC monotherapy. If for some reason the specialist has indicated long-term dual antiplatelet therapy at discharge, then again, it's a case of seeking specialist advice. If you need to introduce an anticoagulant, the situation's changed. They probably won't want triple therapy, but they might want a single antiplatelet with the DOAC going forward. It's a bit of an evidence-free zone. There's no evidence that says dual antiplatelet therapy is beneficial long-term, but specialist cardiologists in particular are a little bit wedded to their antiplatelet therapies and sometimes reluctant to get rid of them completely. Just to note as well that when you are using anticoagulants with an antiplatelet, do consider adding a proton pump inhibitor. We know that that protects against upper GI bleeding. It doesn't reduce the risk of lower GI bleeding, but will protect against upper GI bleeding. So what do we need to think about with Sally? We've had a conversation with her about a DOAC. We've gone through the process of a shared decision. We've decided what DOAC we use and initiated, but there are other issues for her that need to be considered. Her blood pressure control isn't optimal. So we might consider, for example, increasing her ramipril, and she is prescribed a statin, but she's on a low dose of a high intensity statin. But for second prevention, NICE is clear that we should be using, if it's tolerated, high dose, high intensity statin. So rather than a Torva 20, she should be on ideally a Torvastatin 80. So another conversation about increasing to high dose, high intensity statin. You don't have to do all these changes at once. You might say, well, I'll bring you back and we'll discuss the statin at the next visit. But it's important that we do address all of her risk factors as intensively as we can. Otherwise, we're not doing the best that we can for her. So within the pack, we do have guidance on managing high blood pressure in patients with AF. The first is, how do we get an accurate blood pressure reading? And that issue around the fact that automated blood pressure devices are not accurate in patients with AF. They will give a reading most of the time, but it won't necessarily be as accurate as we would like. And if you do repeated readings, so like 16 readings over 4 days, 2 in the morning, 2 in the evening, calculate the average, you'll get a much better idea of the patient's blood pressure control. The only other alternative to this is face-to-face in practice manual blood pressure. So that's the other alternative. You could bring them to the practice and have it done manually. We've seen that already. So NICE treatment pathway, obviously with or without AF, we should still be following this NICE treatment pathway, looking at optimizing the dosing of drugs at step 1 and then stepping up treatment with the addition of another drug at step 2. There is some evidence that 2 drugs at low dose are more effective at lowering blood pressure and associated with fewer side effects than optimizing to the top dose of every drug before going up to the next step. That's a conversation to have with the patient, really. Many patients would prefer to stay on one drug at a higher dose than have to have additional drugs added in. So it's a shared decision really about whether to add a new drug early or whether to keep pushing up the dose of the ACE, the ARB, or the calcium channel blocker. You risk more side effects going that way, but it does minimize the pill burden for the patient. And obviously important that we consider cholesterol and managing cholesterol within the context of people with AF. So it's easier in some ways with patients with pre-existing cardiovascular disease. We know we should be looking at lifestyle factors and using high-dose, high-intensity statins. For those with no pre-existing cardiovascular disease, we're talking prime prevention. We need to do Q-risk scoring. Unless they have CKD or type 1 diabetes, those patients should automatically be considered for a statin. But we should offer offer statins for patients with AF if their Q-risk score is 10% or more over the next 10 years. We also have resources around how to deal with statin intolerance and managing muscle symptoms and abnormal LFTs in patients who are taking statins. So common issues with statins are the shared decision to take one in the first place, the issues of statin intolerance when you start prescribing a statin for a patient, and then how to manage their muscle symptoms and their, if it happens, abnormal LFTs. This is our pathway for second prevention, simplified version of the NHSE pathway. So simple steps: is the patient on high dose, high intensity statin? So that will be a Torva 80 or Rezuva 20 really. And Sally wasn't. So the first step is to see if we can make that happen by increasing the dose and obviously reinforcing lifestyle and dietary measures. And then review them again within 3 months. Anytime after a month or so is sufficient to let the statin have its effect. NICE say we should reduce non-HDL cholesterol by 40%, but you're probably aware now that the QOF now has a non-HDL target of 2.5. So we should be trying to push patients towards that target. If they're not at target, is it because they're not taking the statin properly? Is it lifestyle issues? If that's not the case and they're on high dose, high intensity statin, there's the option to intensify therapy. So we talk about initiate statins, optimize to high dose, high intensity statins, and then intensify therapy. Drugs like ezetimibe, or the injectable therapies, inclisiran, if the LDL is still greater than 2.6, or the PCSK9 mAbs, if the LDL's above 4 in most cases. And then links to NICE and other elements. So if a patient can't take a statin, NICE currently recommend ezetimibe with or without bempedoic acid as a starting point. Prime prevention is even easier because there's only a couple of drugs involved, really. So patients for prime prevention should be on a high intensity statin, so atorva 20 or azuva 10. They should aim for a 40% drop in non-HDL cholesterol, again checking adherence and tolerability. Then you can consider titrating the statin if they're not at target, and if they're still not at target, the addition of ezetimibe is the next step. Where patients can't take statins, ezetimibe and bempedoic acid again are options for these patients. So fairly simple steps to get to optimal therapy. So other things that we need to make sure we're considering is when do patients need reviews, and the review is really determined a lot by the creatinine clearance. So the absolute minimum is that patients on DOACs should be reviewed annually, and that should include a full blood count, renal and liver function checks, and involve calculating the creatinine clearance, so we need a body weight. And at that visit, we should be checking the dose. But some patients require more frequent testing. So patients whose creatinine clearance is between 30 and 60 mils per minute should be having 6 monthly checks. And really, the 6 monthly interim is the renal check, just to make sure that the renal function hasn't gone off and the dose is still correct. Patients who are over 75 years and or frail should also have 6 monthly checks, but that needs to be a full check of full blood count, renal function, liver function, weight, calculation of creatinine clearance again. And those who fall between 15 and 30 mils per minute creatinine clearance need quarterly, so 3 monthly blood tests, because there's a high risk that the renal function might go off. And then obviously, as clinically determined, you may need to do more regular checks or individual checks. Lots of digital resources in the pack to support patients with a diagnosis of AF, from resources that can be found, say, on the British Heart Foundation website, videos on starting anticoagulation from a patient perspective, information from organisations like the AF Association and Anticoagulation UK, and then all the broader cardiovascular resources, so diet, smoking cessation, alcohol, exercise, all the things we want people to do to stay healthy for longer. And some more digital resources to support your clinical management, particularly around where to access the Cockcroft-Gault equation, so the standalone calculator, e-learning around AF available through RCGP, if you remember. We've got a locally commissioned toolkit, the AF toolkit, and resources to support the wider cardiovascular risk factors, hypertension in particular, and lipid management on the UCL Partners website. And just finally, a few bits about warfarin and switching. So important that those patients who have AF that need warfarin are appropriately anticoagulated. Unless there's other things like prosthetic mechanical valves in place, for patients with AF, the target INR is usually 2.5, and the range we're looking for is between 2 and 3. All patients on warfarin should have their INR checked at least 12 weekly. If their control of INR is poor, they will need more frequent checks. And we should look to calculate their time in therapeutic range. So if people aren't within that 2 and 3 band, or if they have issues like high INRs regularly or low INRs regularly, or a time in therapeutic range less than 65%, they should be pretty urgently considered for alternative like a DOAC. But take into account some of the things that might be affecting control, like adherence, concurrent illness, interacting drugs, diet, and alcohol consumption. But it's nice to say that anyone on warfarin for AF, unless there's another mandated reason to need warfarin, we should be considering DOACs. We've got guidance on switching warfarin to DOAC so that it's done safely, so that you identify any reasons why it's not safe to switch, and taking into account all the monitoring you need to do, calculating the creatinine clearance, which DOAC to use and what dose. And then the most important step here is step 7, advising patients when to stop the warfarin and start the DOAC. Ideally, the patient would stop the warfarin and have an INR check done every day, and then when it falls below 2.5, you can start the DOAC. But the reality is that's not practical. So based on the INR, you may have to stop the warfarin, but not start the INR. Sorry, not start the DOAC for a day or 2 after the warfarin stopped to allow the INR to fall. So if it's above 2.5, you might withhold the DOAC for 48 hours and then start the DOAC to allow the INR to drop. So we've got guidance on how to undertake warfarin to DOAC switching, and also guidance on DOAC to DOAC switching. There has been more DOAC to DOAC switching because of the edoxaban procurement, or the DOAC procurement, I should say, the recommendation to use edoxaban first line. But around 10% of patients will need to switch between DOACs, not linked to any commercial arrangements or financial considerations. If they get side effects from one DOAC, it's worth switching them to an alternative to improve compliance. So again, really important that we think about how we go about the process to safely move someone from one DOAC to another. And the biggest issue again is in point 7. When does the patient stop one DOAC and start another? Essentially, the day before the switch, the patient takes whatever DOAC they're on as normal, and the day of the switch, they start the new DOAC at the new dose and the new frequency. If they're switching from once daily to once daily, it's pretty easy. If they're switching tomorrow, take the DOAC as normal today, maybe in the morning, maybe they're on, I don't know, rivaroxaban, you're moving to edoxaban. Rivaroxaban is normal today, edoxaban at the right dose from tomorrow, once daily dosing, easy. The difficulty happens if you're moving from twice daily to once daily, or from once daily to twice daily. So for example, if you're moving someone from apixaban twice a day to edoxaban, what you really don't want them to do is start taking edoxaban twice a day. So really important that they understand that this is now a once daily drug. They don't need to take it morning and evening. And for switching twice daily to a once daily, it's normal dosing the day before. So apixaban in the morning and evening as usual. When the apixaban is due the next morning, the alternative drug, edoxaban or rivaroxaban once a day, can be started at the right dose. Really important to reinforce to the patient, don't take it twice a day if you're moving from twice a day to once a daily drug. So I'm going to finish talking there to leave us some time for questions. I'm going to stop sharing my slides because then I can see you guys. I'm hoping I can anyway. It will let me stop sharing. There we go. I can see there's a few people on the line. I'm not sure whether there are any questions in the chat box. So a question about bempedoic acid. Bempedoic acid does cause problems with the Achilles tendons. There's tendon ruptures reported with bempedoic acid, so it's something we need to remember. It's in our pack to highlight the issue of Achilles tendon issues for those on bempedoic acid. It's not a massively frequent event, but yes, your patients with Ehlers-Danlos might be at higher risk. So switching to edoxaban. Yes, we don't know where we are at the moment with the price of apixaban. I don't think they've been asked to specifically halt And obviously some patients will need to switch for clinical reasons, not cost reasons. This month, edoxaban is very cheap, but we're waiting for the outcome of a court case between BMS, Pfizer, who make apixaban, and the generic companies. We will know by the end of this month whether we have another 18 months of uncertainty around apixaban prices, or whether we will have loads of generic in the market and everyone will be wanting to use apixaban. So keep watch this space. Obviously, those patients who are currently on apixaban, we're going to make some massive windfall savings this month. But until this court case happens, we won't know whether that's going to be maintained. So someone's highlighting that GPs aren't aware of bempedoic acid risk. Well, it's clearly highlighted in our pack, if nowhere else, that there is a risk of Achilles tendon ruptures with bempedoic acid. So we are trying to make sure people are aware of it. We have an info sheet on all of the newer drugs, inclisiran, icosapent, bempedoic acid, in the lipid packs. They're not in the AF packs as such, but you are cross-referred into the lipid packs. I can see someone's got their hand up. Elena, do you want to come on screen and ask a question? Or was that a mishand? No, I'm not getting anything from Elena. Anyone else got any questions about AF? Where are the lipid packs found? While I am speaking to you, I'm going to put into the chat box the link to all the UCL partners proactive care frameworks. I will just copy and paste it into the chat box now. So we have hypertension, AF, lipids. Hopefully that link will work. It will save it. It's just coming up now. So that's the main website. If you scroll down on that page, you'll see lots of boxes that contain the resources. So the search and risk stratification tools that I talked about that will run across your AF register. We have similar for hypertension and cholesterol, identifying patients with suboptimal treatment that need intervention. For the, I'm not sure. Oh, I don't think that's right. Let me try again. Hopefully this search and risk stratification link will work. So that it's all free to download. Actually, it doesn't seem to want to let me. It seems to keep putting the same link up. Let me try once more and share it and see if it's, because that's meant to be the search and risk stratification tools. That's what's on my screen, but it doesn't seem to be pulling up the correct page. It might be because to access the search and risk stratification tools, you need to put in your just basic contact details. So if we change anything, if we spot an error, we can let you know that we've updated them. And then the CVD resources are on the page I've just linked in now. It says CVD resources. You'll find the AF pack, blood pressure, lipids, which includes familial hypercholesterolemia, and diabetes there. And in November, we are launching a heart failure pack. So our newest pack is heart failure. We also have COPD, asthma, and severe mental illness as proactive care packs as well. So encouraging people to think proactively about the patients that will get the most from early intervention. So those links are now in the chat box for you. Are there any other questions? Rapture's just dropped the evaluation forms into the chat box for you, so you can fill out an evaluation. We're particularly interested on other topics you might want us to cover. Obviously, soon we'll be talking about heart failure because we've got the new heart failure pack coming. But do let us know if there are other clinical areas that you think you want us to cover in a webinar, and we can see if we can put one of those into the schedule. I can't see any more questions coming through, so I will give you a few more minutes of your time back before you're next probably rushing on to something at 2:30. Thanks very much for coming today. Do let us know if there's anything that UCL Partners can do to support you, particularly with the CVD prevention work, but also wider if there are specific issues. And I look forward to seeing you all again soon. Thank you very much.